Thank you very much for having me here. My name is Arif Kassam. I am the Vice President of Community Development for Clarity Health Services. And I was going to say that I'm really excited to be here, but I'm not quite sure I'm as excited as our friend Leighton there. I'm not sure you could handle another person quite that excited. So makes me wonder what you could do with a different topic. So,
you can hire me, I can talk for your outfit.
Yeah, be careful what you wish for. Everybody gets drafted. As you'll hear from Hiroshi, who's one of our customers, just found out. Well, thank you, Eric. Thank you, Mariella, and to the board. I am excited to be here. As I've gotten to know you and the leadership team at PSW, I'm really impressed about how you're organized around your mission and how engaged the membership is with the leadership. It makes a huge difference. That's what makes us successful in our communities, and it is what will make you successful in the years to come, because things are changing, and that engagement is required as you move forward. So for many of you, you haven't heard about Clarity Health Services, and my objective this evening is really to share with you what Clarity is and what we do, and why we're here. Clarity is a small, rapidly growing company in Seattle. We're fairly small. We're about 22 people. Our service helps communities like yours. I guess I forgot to do that. Our service helps communities like yours coordinate care on behalf of your shared patients. 3 years ago, we launched our service in Pierce County with the support of Northwest Physicians Network. And Mariella's been tracking us since then. Excuse me. 6 months ago, we launched in Spokane, and we'll be launching in Anchorage in next month, in May. The reason I'm here is because we have been working with the board to consider a launch in Olympia, in Lewis and Thurston counties, and we're working towards that goal. So Clarity started by focusing on care coordination in the outpatient space, in referrals. This month, we're extending what we do to the post-acute care setting, and we're starting with discharge coordination at 2 hospitals, one with Good Samaritan Hospital in Puyallup, and second with Deaconess Hospital, which is part of the Rockwood Health System in Spokane. So let's, since a lot of you don't know much about us, let's go through a little bit of an overview on Clarity. I'm sure a lot of you know that while you can do a great job for patients when they're in front of you, when they're in your office and in your care team, your peers, in your setting, you can take great care of them. Care breaks down, however, when there are transitions of care, and particularly when those transitions occur across organizational boundaries. When they go from your setting to a hospital, to a consultant, or beyond that to secondary and tertiary referrals. Care coordination requires better communication. And first and foremost, what Clarity is a communication platform. So we use a web-based application to facilitate care transitions from any care setting to any other care setting, from outpatient referrals to post-acute care setting and post-acute transitions. Clarity is not software, although we do have a web-based application. We are not software. We are a service, and we're people that work with you to engage your partners in care, to offload unproductive work, and to facilitate broad-based care coordination in the community. And by broad-based, I mean across all types of care settings, not just physician or provider-led care settings, but clinical services, the acute cares, and the post-acute settings. You access Clarity through a low-cost monthly subscription for the service. And the people that receive those care transitions, the recipients of them, pay a service fee for the work that we do, and I'll explain a little bit about what that is. There is nothing to buy. There is nothing to install. We are not an EMR. No practice individually covers the cost of the service. And the reason is we designed that business model actually very deliberately. Care coordination is a shared effort in a community. And Clarity is a shared expense in that community. So this describes what we currently do. There should be absolutely no question in this room why we don't do a great job of coordinating care across independent care settings. The common denominator in care coordination is the fax machine. And the biggest challenge with a fax is that once you've sent it, you've lost complete control. You have no idea what the status of your patient is. Did they go? Did they ever schedule? Were they seen? What happened to them? You know what notes you get back, but you certainly don't know which ones you didn't. And that's where care coordination breaks down. So that is not accountable, particularly when you find out from the patient when they return to you what happened. And we've seen people struggle with that and articulate that very poignantly. For you to be accountable to your patient, you need visibility to that patient across the boundary of your own organization. And that's what Clarity is about. So let's just describe a little bit about how Clarity works. We use a web-based application as a platform for sharing information between you and your care partners. It's used for communicating, for tracking patients, and it's used across an entire community. Anyone can participate. Creating a referral online or through a direct integration with your EMR takes seconds. Chart notes, labs, imaging results, prior histories are attached to support that transition of care. That is your accountability to your partners. However, care coordination takes work. And in order to allow you to coordinate care or allow your current staffing to coordinate care on behalf of those patients, we provide insurance verification, insurance authorization for things like imaging, where it's fairly complex, and things that are fairly simple, where you may need a pre-authorization for a particular type of procedure, or even a consult. And we offload that unfunded mandate from the primary care providers, and the consultants get a schedule-ready order at the time of receipt. That is our accountability to you. We work together then to get the commitments of the consultants that you work with to provide acknowledgement, patient status, and a visit status. Most often, if the visit was successful, a chart note or a consult note returned to you. And the commitments we're asking for are not that they send back a chart note, because you get those today. But we ask for a shared commitment around service. And that's according to a community standard which you set. In Pierce County, that shared commitment, that service standard, is 24 hours to acknowledge the receipt of an order or of a consult, 3 days to provide scheduling status, which could be a scheduled date. It could be, I've tried 3 times. It could be, I can't get a hold of them because the number's wrong. And that is their accountability to you. Finally, all of those transactions, all of those referrals, transitions of care, all the chart notes, all the labs are archived with the patient record online and shared amongst a care team. And what defines a care team is anyone who actually creates a transition of care on Clarity or who receives a patient on Clarity. You're connected to that central patient record. In Pierce County, we have 500,000 patient records online, over 125,000 referrals, and each one of those has a unique set of a care team. So it's truly patient-centered care. So we are a communication system first and foremost. I thought what I'd share is, well, what does that communication actually look like? So I think a lot of people are familiar with, well, I send a referral out and I get a report back, but there's a lot more that goes on in coordinating care. So this is an example. I took an excerpt of a real referral that just happened last week. Jean Taylor is a referral coordinator at Summit View Clinic, which was one of the site visits that some people from PSW came up to Pierce County for last week. And she is inquiring, if you start at the bottom, it's kind of like a blog, so start at the bottom. Jean is saying, hey, what's going on? I don't have an appointment date for this person. And the reason she knows that is that Clarity tells her there's no appointment date for that person. Point number 1, at least you know. Number 2, the person who responds is at a cardiology office, cardiac study center, a group of 16 cardiologists in Puyallup. And she says, number 1, thank you. And actually, that little 2 words, those little 2 words, have made a huge difference to Cardiac Study Center. They've gained about 5 points of market share just by thanking people for the referral. And it goes through, there's some documents added, and then there's a clarification, by the way, I don't have a chest x-ray for this patient. And that all happened really over very, very little time with very little effort. Both of these practices are very sophisticated and have had EMRs for years. And that conversation would have taken days or weeks if it ever happened at all before, with a great deal of effort. So that's what I mean by communication. Sometimes very, very simple. So patients tracked. I talked about that earlier. Well, what does that really mean? One of the challenges in being a primary care medical home is knowing what the status of your patients are. Once you send a referral out, do you really know what happened to them? So this is a sample of how patients are tracked in Clarity. If you look, there's, working from the left, there is a green check mark beside some of those patients. This is a work list, so everybody works off work lists in Clarity. It's a very simple web-based app. And the green check mark tells me that that patient has been scheduled. If I hover my little mouse over that green check mark, it'll tell me what the date and time of that schedule is. So I can take that as in a primary care setting and update the chart with that information, or leave it there. At least we know what's happened. The second column is the stage, and what that tells me is each one of those 4 patients is at a different stage. One has been scheduled, one they've acknowledged it but haven't yet scheduled, one they've actually delivered a report, and the other one they've said that the service was delivered but I haven't seen the report yet. So I can take any one of those different stages, drop it to a queue, and an AMA, like let's say that stage said patient canceled. Well, what are you going to do with that information? A, without clarity, it would be very difficult to get it. And two, without it, it'd be very difficult to action, because you'd be doing them one at a time. This way, you can aggregate, filter on which patients cancel their appointments prematurely, did not get seen, drop it to an MA, call the patient, get them in there. You are responsible for the care of that patient. You are responsible if they didn't go. And here's a way that you can manage that accountability to the patient. So that describes how clarity works. What it doesn't describe is what we do. What's interesting about what we do isn't the efficiencies we provide. It's not what we're about, and it's not what you're about. We're not in the business of, we're not in the business because we enjoy calling TRICARE 100 times a day. I suspect you don't either. But we do it, because that goes back to our accountability to you. What we are about is enabling people like you in a community that's organized and focused and has a mission around better care for patients. Set, measure, and manage to shared commitments, shared standards of care. We allow you as a community, and we've done this already in Spokane and in Pierce County, to tackle the challenge of care coordination. We work with you as partners to help foster a higher standard of care, and through transparency, and I'll show you what that means, through transparency, promote greater accountability. So I talked about transparency. Transparency comes in the form of a report. You know, if as a community you want to promote accountable care, then you have to make it measurable. You can't be accountable if it's not measurable. And you can demonstrate clinical integration by how well you serve your peers, your team. And if you do, your patients in turn will also be well served. That's what this report is about. Healthcare cannot, and is and cannot be, an individual effort. And so what we do is we bring together these community reports. And there's some very simple metrics in here. So I talked about what those standards were. Clinical attachment rate is, did you actually send appropriate clinical information with an order or a consult request at the time that went out? When we started in Pierce County in an early beta, that number was 15%, 1-5. Today, it's 95%. And we can track that, and you can manage to it. Because it doesn't impact clarity at all, but it does impact the care that your patients get. The other ones are just the response metrics. Now, there's actually a funny story about this. So this is actually the second report. Hiroshi, you'll remember this, because you were right there in that meeting. In any community we have, we put together a leadership team. Hiroshi's on that. He got drafted early. And one of the members of the team was the oncologist. And the very first report we produced, one of the numbers, I think it was clinical attach rate, was significantly lower than this. And it was lower than all the other practices. So I'm married to a physician. You guys are all very competitive. So we have a group of 5 physicians sitting in a room looking at this report, and one number is low. And anybody guess what the first reaction is? Attack the data.
Yeah, must be wrong.
Okay, so the first thing is attack the data. What's the second? Attack the messenger. So here I am sitting with a bunch of physicians, getting attacked by an oncologist. And the guy sitting beside me is a radiologist. And he puts his arm around me and he says, you know, Sibel, it really does suck. It took her all of 24 hours to go from 35% to 95%. You all know what the right thing to do is. You just don't have any data. You don't know what's happening, and you don't know how to manage it because you have no information about what's happening. So that changed care. It changed outcomes. The radiologist that was on the receiving end of that is the founder of Diagnostic Imaging Northwest. And he pulled me aside a few months later, and it was actually really humbling because we don't get involved with patients. We don't touch the patient. We don't talk to the patient. And he said, Arif, you know what? You've allowed us to do a better job. I believe we are doing higher quality work because of clarity. And that to me was astounding. So let's get a couple things out of the way. Here's some of the things we hear. But I already have an EMR. So let's be really clear. EMRs do not help you coordinate care. They just don't. They ultimately convey information through a fax. Secondly, and by the way, if you have an EMR, we'll integrate with it. Most of the issues actually with EMR integrations have nothing to do with the EMR. It has to do with, can you afford the price that your vendor is going to charge? We don't charge anything for an integration. We're partners. I don't think that's the same with the EMR vendors, but if you can't afford that, or if it's not reasonable, or you can't get access to the technical resources, we'll integrate through fax. Send us fax, we'll load it in. And thirdly, use it like 90% of the EMR-based practices on Clarity actually are, and that is just use Clarity. Upload the documents, copy and paste them in. That's the simplest form of integration. It still saves time. You're still offloading all the insurance work so that what your staff is focused on is something productive rather than talking to Aetna for 3 hours. So for the consultants in the room, I already do a great job. We don't need this. Great. Then several of the practices that are on Clarity have used our report as a marketing tool. The marketing reps take that number at 97.5% compliance with service standards that you've set, and they take it out there and market it. Why shouldn't they win if they're better? And the third thing is, well, I can't possibly do one more thing. And obviously the answer to that is, well, then do less. Get rid of something that isn't adding any value to you. It's not adding any value to your patients. And, you know, for the consultants that say we do a great job, I suspect you aren't, as primary care providers, getting 20 phone calls a day with information about the status of your patients. Because if they did do that, you'd call them and ask them to stop. You can't handle another 20 phone calls a day saying, hey, by the way, this patient just scheduled. But you do need to know that. This is just an effective way to do that. So here's what I think the opportunity is and what we're working with Mariella and the board on. I think the opportunity here in Thurston and Lewis counties is to help preserve independent practice in the face of empowered patients, consolidation around integrated systems, declining reimbursement, and God forbid, what we saw earlier, increasing regulation. You are going to have to demonstrate how you are organized and are clinically integrated as a community in order to be successful moving forward. You can't demonstrate that without something that you share in common. You can't do that unless you can demonstrate how you do a better job. Coordinating care, and you can actually show that to the stakeholders that you have. Your peers, your patients, and the payers. Clarity provides that opportunity. You can, with Clarity, share a panel of patients. When I talked about the 500,000 patients in Pierce County, that is a panel that that community shares. My job, by the way, is to see that you're successful doing that. So just a brief overview of how we actually go about putting together a community. Our model is actually fairly simple. What we need to be successful is broad participation in the community. And our business model demands it. Because from day one, we take on the full burden of a primary care office sending all of its referrals out, whether or not anybody else is online at the other end. So for the same subscription fee, we take on all that work. And I'll show you a little bit in the next slide why it doesn't pencil out. So we start with something that we call a micro-community. And a micro-community is a significant portion of primary care, excuse me, a significant portion of primary care, enough that you have leverage. And what we call the anchor tenants in a community. Anchor tenants are the most often referred to groups of consultants. It's cardiology, GI, orthopedics, and radiology. And with those, at least one of, if there are multiple practices in a community, at least one of each one of those come together as a micro-community and start using Clarity. That micro-community becomes the internal reference in a community as to what is possible. What does clinical integration look like? What does it feel like? What is the work involved? So that you're not traipsing around looking at reference sites somewhere else. You are the reference for your community. Number two, we extend to aligned partners. And this could be other types of consultants, other clinical services, things that are a little bit less volume oriented. So that micro-community actually accounts for about 60 to 70% of all referral transactions coming out of primary care. And so it's a good place to start because you'll get immediate value as soon as that micro-community is up and running. And usually we add hospitals at the end. And the reason is that typically, at least our experience in Pierce County, is the hospitals are really trying to figure out how to get you either acquired or get you to use their system so that it's, you're locked into a particular type of environment. But in this case, here in Olympia, I'm actually quite hopeful we'll start with one of the hospitals. We've got a discussion going on right now that's fairly advanced. We've got very positive indicators from a number of people that came up and visited some sites in Pierce County. I think we are pretty much ready to move forward, Mariella, and you can speak to that. And so I see no reason why we will not be moving forward. We're certainly committed to you, and I believe we have commitment from you. So this is what the numbers look like. For $70 a month, whether you're a primary care or a referring specialist or a referring consultant, that covers all the outbound referrals that you do. There's no other cost in primary care. And it doesn't come anywhere close to covering the cost of what we do. Nowhere close. On the other end, what you need to be successful is you need the people that you refer to be online and to use Clarity to drive that information back to you in a way that you can utilize. And so do we, because the consultants pay the bulk of our cost. And those costs range for anywhere from $3 to $7.50, depending on the type of referral and how much work is typically associated with that. So because we have this kind of business model, until we achieve balance in a community, it typically costs us a fairly significant amount to get started. Each community, we estimate, will be costing us about $250,000 to get to balance. But it works, and it works really well, because unless you're successful, we're not successful. And so we're very aligned with what you're trying to achieve. But it does mean that in any community in which we decide to launch, it's as much an investment decision for us as it is for you. So while you are assessing whether or not you want to work with us, we're assessing whether or not we want to work with you. And what I said about you being organized around a mission is true. I mean, that's what I've been looking at as we've had our discussions. So just
Sorry, clarification.
Yes.
Back to that slide.
Absolutely.
So first line, if you are someone who sends out referrals, that's $70 a month. Second line, if you have referrals coming into you, those are $3 per referral. If you're, for instance, a gastroenterologist who sees the occasional subxiphoid pain that's actually a cardiac pain, and you then secondarily refer the patient off to a cardiologist, you're actually in both categories. Is that correct?
Yes. So you don't pay for that secondary referral.
You don't. Okay.
What it does, though, is the cardiologist will pay for that referral.
Okay.
But what's important is you, as the primary care physician, can see that happening.
Okay.
And if there's a tertiary referral, if there's an MRI, a cardiac MR that happens, and a report that comes back, you have that.
And then the last line, which you've not really broached on this circumstance, when hospital generates a discharge summary, they don't always
Is it when or if?
Yeah. They don't always CC everybody that might be need to be in the loop.
That's
so
shocking.
basically, your repository function comes into play then.
Exactly.
And so if I got left off the list, but I've got the patient, but I am a subscriber, and that patient's sitting in my office, I can log into the site, I can pull up that discharge summary.
Absolutely.
So you won't be left off the list. If you are a physician of record, either the admitting physician or primary care doc, you will get a message saying that your patient was discharged.
But I might be, a consultant that did, maybe sees the patient as an outpatient but wasn't involved in that hospitalization, but maybe.
That might be a case where they wouldn't have.
Right.
Yeah.
Now, remember, when a patient's discharged, we know, if you're the primary care provider and they're part of that panel, we know that you're part of that panel, that you own that patient relationship. So we can inform you even though the discharge paperwork doesn't formally.
Yeah. So that'll happen proactively, but there's still this fallback.
Right.
Functionality that, okay.
So let me, I wanted to share some experiences with you because we've had some site visits. I've got Hiroshi, who's dying to get up here and tell you about his experience with Clarity. And I thought what was important is, I don't think Hiroshi, that it matters in getting into the details of how people use it. But I think the experience of working with us as partners and engaging the community would be important for them to hear about. So let me introduce Hiroshi Nakano. He's the CEO of South Sound Neurosurgery. Was drafted early on. Hiroshi, what you don't know is Peter and I had conversations about you in the background before you really knew much about us. As I said, in every community we want a leadership team. Hiroshi demonstrated very early on that he's got that material, and so we wanted him on our team. And so let me introduce Hiroshi.
Thanks, Arif, and thank you for having me here tonight. Like Arif said, I'm not going to go into much detail. He gave you some examples of the interactions that are happening between my staff and the other physicians in Pierce County that are on the Clarity system. So that happens over and over and over again, and all I can tell you is that my staff love it. They're off the phone. They get responses. If we get a referral that says back pain, we can go back and say, well, can you give us a little more? Right, and they don't have to pick up the phone, so it's a big deal. It's a really big deal to my staff. So South Sound Neurosurgery is a neurosurgical practice. We do mainly spine surgery and pain management. We have several pain management docs. Our big thing is outpatient spine surgery. We have our own surgery center. We have an MRI on site. So, and the biggest point I want to make today is that the reason why I got involved after seeing some of the information that Clarity can prove is that our existence depends on private practice referring physicians, right? If you guys dry up our referrals, I'm a dead man. I'm fired tomorrow, right? So that part is really important. We're the only neurosurgical group from Bellevue to Olympia still in private practice. So I'm not competing with other neurosurgeons. I'm competing with Multicare, Franciscans, and the millions of dollars they spend touting their neuroscience program. So that's what, that context is what I'm up against, and the strategic decision about why I want to get involved with something like Clarity. Because again, if I'm not connected to you, I'm toast, right? So a little bit about my background, just so you understand. Unlike Mariella, I'm a retired, reformed IPA administrator. I ran Valley Physicians Organizations eons ago in the last form of healthcare reform. I've also been on the plan side. I was the director for provider relations at KPS Health Plans, currently CEO of South Sound Neurosurgery. So I've played across the spectrum a little bit in healthcare. The other thing is in the practice context, which I did talk a little bit about, we, like probably every other consultant, feels like we do a bang-up job. We got great doctors, we have great technique, we do wonderful things for the patients, we fax every single chart note back to you guys, but we're still disconnected, right? It used to be in the old days, you'd see my surgeons in the lounge or the lunchroom at the hospital. That never happens anymore. So we have to figure out a way to stay connected. And so that's the overall context of why we really got involved with Clarity. And as Arif was referring to before, I'm part of this Physician Leadership, Practice Leadership Council. So a lot of the value that I'm getting out of Clarity is not just the technical aspects of sending referrals back and forth, attaching notes back and forth, is the fact I'm much more engaged with my medical community than I was before Clarity. So practice managers, in fact, I have a lunch meeting set up for this Friday with some of you clinic. Some of you may know they're part of the PCMH pilot in the state of Washington. So they decided that they were going to do group visits for chronic pain patients as part of that, okay? Well, that's really attractive to me because we treat chronic pain patients as a specialist. So because of the relationship, I was able to say to LaDonna, we need to get together and we need to talk about this because we need to figure out if you're managing patients in a different way, then you probably have a different set of expectations about what you want from us. And it's important that we sit down and talk about that. And they were willing to do that. So completely outside of Clarity and the referrals going back and forth, and by the way, my referrals from some of you did increase once we're on Clarity. They did, right?
Yeah, quite a bit.
Yeah, absolutely.
You should give us some commission.
Remember we had that discussion before, Arif. Careful, don't go there. But now I have, on the administrative level, a relationship. Friday we'll have a much more in-depth relationship clinically. And hopefully, as we try to figure out how to manage these shared patients better, then clarity will help us get more and more specific about what's the information we really need to exchange. How do we want to do it? What information do we need? What does the primary care doc need back? Because we want to send them back, right? But we want to send them back in a way that you can do something with them going forward. So, again, we talked a little bit about efficient practices. We're certainly seeing it. I didn't have to lay off I never got so productive I could lay off a person, but they're happier, they're busier, and they can spend more time engaging with the patient rather than, sorry, could you wait, I'm on hold with a health plan, you know, so they can be more engaged with the patients up front. In terms of powerful relationships, we talked a little bit about that. Even on the admin side, I'm getting more powerful relationships with the medical community, and my doctors are getting more powerful relationships. And then the high performance care community, we're starting that discussion now. From my perspective, we'll talk about chronic care, chronic pain patients. Hopefully that'll lead to more advanced things about spinal surgery. And from there, who knows where we'll go. So anyway, that's all I have. If you have any questions?
Well, just to provide a link back to our first patient from Layton, is that you may not be able to lay off staff, but those staff may be involved in more productive activities, such as calling up that patient who had not been seen for 12 and a half months, calling them at 11 months and saying, hey, haven't seen you in 11 months, can you get in here before this date so I can see you again in less than 12 months? And that would be a much more productive use of time.
Yes, and the fact that I can get my staff off the phone. I mean, one of the things that I know I've talked to Peter and Arif about is that I'm planning on embarking on a fairly major customer service initiative within our practice, okay? And so that interaction between every single person in my staff and my providers and the patient is really important, because our survival is really going to depend on it. Because if we make a patient mad, if we drop the ball for whatever reason, whether it's administrative or clinical, you guys are going to hear about it.
Or if they just get into the clutches of the emergency room at one of those hospitals that owns a competing practice.
Right, right. So being able to take some of that burden off and allow them to be more present with our patients is an important thing. Any other questions?
Well, Arif, was it accurate that the typical experience is it takes about 90 seconds to load a referral for primary care?
It's about right.
90 seconds, a minute and a half, 2 minutes maybe to do what they can't get the phone to be answered by your insurance
Right.
company at that time. So.
Right. And, you know, the churn associated with, I think everyone in primary care knows that when you send out a referral, things don't always go smoothly. Sometimes it can lead to 2 or 3 phone calls back or faxes back saying, hey, we're missing some information. So this way, it's not a fax. It can't get lost. It can't get misplaced. You know, it just never goes missing. It's always available. And it's available to the, you know, in large consulting practices, it's not unusual to have, you know, different workflows, different people asking for the same information from your office. Because internally, they don't have a way of distributing that information effectively. And that's really common. It's just, it's a really busy world. Here, everything is in one place, anybody can access it. So I wanted to take a minute just to have a newfound friend here come up and talk about the site visit. But before you do, this was Brendan Longmire was one of the people that came up on Thursday, I guess it was 2 weeks ago. And we sat over lunch, and she said, she put this in writing, which I thought was wonderful. But she just said to me, I did not expect to see something that I was just so excited about. And she said, you are coming to Olympia, are you not? Because I'd be terribly disappointed if you don't. So just to keep you in line, Dr. Faiola. So Dr. Faiola was your physician representative at the site visits, and I'll let him take a couple minutes here.
I've been around enough to be skeptical and entered this process with that attitude. I haven't found them to be evil yet. They represent themselves to be righteous, and they might be. That was actually about the attitude of the site I visited. Physicians Care Northwest was 4 physicians, a couple of mid-levels and the like. And they had a referral coordinator that was doing referrals before I started med school, I think. I mean, this was a lady who was, she's been around. And she was adamantly opposed, as she told us, to this scheme that was crammed down her throat by her visionary physicians in that group. She now would not give it up. She'd rather cut off her arm. I mean, this is primary care. She really believes it saves her time and trouble. And she's got a mixed bag. 2 of her physicians are still paper pushers, and she has to, she gets her stuff together in the old-fashioned way of disconnecting and charting and copying. And the other ones are electronic. And so for them, she prints it out. She gets her cover sheet off their website and then faxes it off. There's a concern about those of us who have made the jump to EMR or are making it, that this may be a step back. They have committed that it will not be a step back. They are prepared to take our faxes directly out of our EMR, and at their shop, they'll put the cover sheet on that's necessary to make the system work. And then we get it back through the system. But that's no longer us sitting at the exam room in the note. That's our staff who would be doing it anyway, as these consultant letters would come in or the consultant fax would come in. You get them by snail mail, you get them by fax, you get them in your hospital box, and your staff is trying to it'd be nice to have them all come back in one system. The PA, the prior auth, is a nice efficiency. I took with me my lead receptionist, Stephanie, and she's convinced she'll save about 10 hours a week. Well, I can do the math, $70 a month versus, 40 hours a month of MA time. That's not bad. So you begin to think maybe this will work. The consulting orthopedic practice we went to, I told them, I don't really care what work you guys do, as long as you get my referrals back to me in a timely fashion. If it takes you 7 staff members, that's okay. But it's nice to know that they're happy too. They were quite thrilled with the system, and they were very happy to, like us, receiving consults back in a uniform fashion. They were getting referrals in a uniform fashion, which makes it more efficient for them. They were getting patients who were appointment ready, so they're serving our needs quicker. One of the things that may not have been as clear as it could be, this is a primary care room, there's not many consultants in here. It's no secret, I think, that most consultants send us back a decent letter when we send them a patient. The first time. You might or might not get the second visit back. When the first one says, I'm going to send them out and do this stuff. I'm going to spend $17,000 to do a workup, half of it repeating what you've already done, and when I'm finished, I'll make some assessment, but I won't tell you because I forget the patient is yours. The system will ensure that if we as a community have defined that what the primary care people want back is your initial letter, we want the next 2 visits, and then I really don't care about every follow-up note maybe, that's our decision, and we want the last one when you think you're finished with the patient. If we define that, that's what they're going to say is a complete circle of care. And if it doesn't happen, we know it didn't happen. And what's more, everybody in the community knows that it doesn't happen with Dr. XYZ. That's, I think, some leverage. and it serves quality care. What we don't have now is closure of that loop. I don't know that the patient never showed up at so-and-so for this consult, and thus that's why they were next in the emergency room. You know? Bottom line, I think there is efficiency in the system. It has some weaknesses and some strengths. They're relatively new. They've only been ready for semi-prime time for about 18 months. That's a weakness. A great strength is they've only been at this about 18 months. That means we have every opportunity to shape this product to meet our needs. They're not going to come in and, this is it, you do it our way. We are still involved in not the ground floor. A lot of the pain has been borne by others, but we get to still massage and shape. And we have the real advantage to surprise them by saying we have an integrated system here in PSW already, and our consultants will be on board from the start, which means that we are getting this two-way feedback in the full loop from the start that makes them happy and likely profitable from near the start. And we'll start out with everything we send is in the repository. Each consultant who sends back is in the repository. We'll likely have at least one hospital on board with discharge summaries in the repository. And with any luck, we'll have at least one or more radiology service in when we start up in the repository. So those back ends, oops, now I got a patient that, you know, I've never seen before, but I know they're in this community because they were seeing Gary Gowan or whatever. And so I can look up their stuff. I can find the cardiology stuff because they don't know who it was anyway. Some guy on the east side who did something. So I think there's efficiency for the system. There's a quality advantage. I think more importantly is that it's one more opportunity for PCPs and consulting physicians to talk to each other. Any opportunity we have to keep our dialogue going, I think, is good. The statement Ben Franklin is said to have muttered was that we can either hang together or most assuredly we'll be hung apart. I think it's preferable to hang together, and this is an excellent platform strategically for greater integration, both clinically and perhaps administratively, even someday financially with joint practices without walls, and a good way to remain independent but still cooperative with each other. So that's my take on it.
Thank you.